Good afternoon, everyone. This is Joyce Fogler from Vantage Point Consulting, and I'd like to thank you for joining our webinar today on the role of the ambulatory surgery centers in the healthcare coalitions. Again, I'd like to thank the IFASC for sponsoring this training through the grant fund, especially for Ann Haddix, who has been a great contact person and is your emergency management representative to IFASC. We do have everyone on mute. If you have a question or a comment during the webinar, please enter that into the chat feature, and we'll attempt to address those as we go along or at the end of the presentation. As with our previous webinars, we will have certificates of training available. If you've registered and are logging in, we will send you those automatically. However, if you have additional people sitting with you in your office, please make sure you send us their names so that we can get them a certificate for this training. Our email addresses will be on the last slide. So our objective for today, we're going to just review a little bit about what a healthcare coalition is and the functions of that. We'll explore the role the surgery centers can take during a disaster within the healthcare coalition geographical area. We'll talk a little bit about what you need to be able to accomplish support during a disaster in your community, or if you are the incident site, and also what you can do to become an active member of your local or district healthcare coalition. So just some background information just to help you understand why we're even having this educational session today. In 2011, there was a presidential directive, number 8, that was distributed in an effort to strengthen the security and the resilience of the United States, making sure that we had systematic preparation for threats that pose a risk to the security of the nation. Within that directive were established 5 different mission areas. Prevention, which is preventing, avoiding, or stopping a threatened or an actual act. Protection, meaning that we want to protect our citizens, residents, visitors, as well as our assets against the greatest threats and hazards. Mitigation mission is doing things to mitigate the loss of life and property by lessening the impact for future disasters, making sure that we can respond quickly to save lives, protect property and the environment, and meet the basic needs of the aftermath in a catastrophic incident, and recovery through a focus on timely restoration, strengthening, and revitalization of the communities that have been affected by the incident. Within that overall directive, there were 4 frameworks established: the prevention framework, mitigation framework, response framework, and recovery framework. And I believe there's a 5th one that will be published shortly, that is the protection framework. And those are just documents that kind of guide particularly the government and the response agencies on how to move forward in those different mission areas. So when we talk about a healthcare coalition, this is the official definition provided by the Assistant Secretary for Preparedness and Response, or ASPR, which also provides us with the grant funds to do education, training, and exercises in preparation for a disaster. So simply stated, a coalition is a group of people that come together for a common purpose. Terms that you might hear regarding coalitions might be alliance, union, partnership, team. So the partners in the District Healthcare Coalition support by sharing assets and information to enhance emergency preparedness capability and proficiency of the healthcare system during disasters. There's a collaborative network of healthcare organizations and their respective public and private sector response partners that serve as a multi-agency coordinating group to assist the preparedness, response, recovery, and mitigation activities related to the healthcare organization disaster operations. The coalition is a collective effort to plan, organize, equip, train, exercise, evaluate, and outline corrective actions as a result of an actual event or an exercise. The coalition works together to promote situational awareness. They conduct coalition meetings. They complete and hazard vulnerability analysis for the communities that they serve. They share essential data and provide advice on decisions made by individual incident management teams regarding information and resource coordination. By having a coalition, we increase the impact of each organization's efforts. Your involvement in a coalition means there are more people who have a better understanding of your issues and people advocating for your side. When we look at a coalition, we're really talking about a whole community, and this is a term that you might hear also discussed with conversations regarding healthcare coalition. Within the whole community concept, we basically want to make sure that we're operating under a common picture, a common operating picture. Any type of a disaster starts local, then it moves to the healthcare coalition. If it becomes more complex, the district within the state becomes involved, and then the next level or tier is state involvement. If the state can't manage the incident, then they look to other states for assistance or interstate cooperation. And at the highest level or complexity of a disaster, it moves to a federal response level. Basically, anytime we have a disaster, our primary goal is to do the most good for the most people. And in order to do that, we have to understand the roles and responsibilities of all the partners to build, to meet our community needs and to build community resilience. When we're talking about a healthcare coalition, there are different agencies that are involved within that coalition, and they fall primarily under two different branches within our government. The Department of Homeland Security it is the Federal Emergency Management Agency, or FEMA, and then each state has a state Department of Homeland Security, and in Indiana this includes the county emergency management agencies, all fire and law enforcement agencies, search and rescue teams, hazardous materials response teams and cleanup efforts, public safety, as well as overall making sure that we're able to provide care for the health and well-being of the individuals in their community that they serve. On the other branch of government agency, we have the Health and Human Services branch, and this includes the Center for Disease Control, or the CDC, that we're fairly familiar with. Again, the ASC program that helps support emergency preparedness, as well as provides funds for training, education, and resources. And locally, or within the state of Indiana, those two programs are managed locally by the Indiana State Department of Health through the Public Health Emergency Preparedness Department, as well as the Healthcare Preparedness Program. And I'll show you how that is split out as we move further in the webinar. When we are developing our healthcare coalitions, developing our emergency management plans, deciding how we're going to respond, there are basically several different capabilities that we need to focus on. These capabilities for the Department of Homeland Security, there are actually 34 different capabilities. 14 of those are based in the response area. And again, this is the Indiana Department of Homeland Security. So these are the capabilities that the Emergency Management Agency and the more the local community agencies would follow in responding to a disaster in your community. Several of these kind of crosswalk with some of the capabilities that from the public health side or healthcare preparedness side that we do. So what you see here are the healthcare preparedness program and the public health emergency preparedness capabilities. As you can see, there are 15 capabilities for public health emergency preparedness. The healthcare preparedness program, which is the side that the ambulatory surgery centers fit into, we have 8 capabilities that we typically work towards managing. I'm going to kind of review those different capabilities in a little bit more detail. One of the documents that you were emailed earlier today does list those capabilities and the functions that they need to address. I'm going to just kind of review those real quickly so that you have a better understanding of the capabilities that we're working towards in emergency preparedness. So health systems preparedness, these are activities for planning, equipping, training, exercising, and evaluating, and define and support the resources that are identified. These basically, it's the community's ability to prepare, respond, and recover from an emergency situation. Healthcare system recovery encompasses both short-term and long-term efforts for rebuilding and revitalization of the affected communities. Again, in simply stated, it's the collaboration with emergency management and community partners to accomplish recovery efforts. The third one is emergency operations coordination. These are actions taken in the immediate aftermath of an incident to save and sustain lives, to meet basic needs, to reduce the property losses, and the effect on the clinical infrastructure and the environment within our community. It's our ability to engage in incident management on site or in an emergency operations center to gather information and allocate resources. The next one is information sharing, which is a means to coordinate the gathering and dissemination of information with incident management, our responders, community stakeholders, and the general public, and our medical partners, both during response and recovery efforts. Or another way to state it is our ability to conduct multidisciplinary and multi-jurisdictional side-to-side and up and down movement of information regarding public health, which is critical before, during, and after disaster operations. The medical surge capability talks about our capacity or our capability to rapidly expand our existing healthcare systems to provide triage and medical care, and addresses pre-hospitalization, hospitalization, as well as receiving hospital surge management. It's critical for hospitals to recognize and plan for facilities that they can't manage a medical surge event alone. They must plan and coordinate with non-hospital partners, which includes ambulatory surgery centers, to make this happen.
Fatality management is the process that occurs in the community and provides for the intelligence sharing and managing of death surges and the need for temporary storage space. It's our ability to coordinate with emergency management, the healthcare sector, the coroner, as well as the medical examiner to ensure that we have proper recovery, identification, handling, transport, and storage in a mass fatality event. Another capability, which is responder safety and health, identifies critical resources needed to ensure healthcare workers are protected from all types of hazards. In order to protect the safety and health of responders and the healthcare workers, we need to make sure that we have personal protective equipment to deal with infectious diseases and provide appropriate training and coordination in those type of events. And the last capability that the Healthcare Coalition works towards from the Healthcare Preparedness Program side is volunteer management, making sure that we can effectively coordinate the use of volunteers to manage an incident. We can do this through registrations of volunteers and determine how they can help the healthcare organizations manage the healthcare needs in a disaster. So when we're looking at a healthcare coalition, this is kind of all the players and how that looks. And as you can see, it really does take a whole community, including the outpatient centers and the outpatient or ambulatory surgery centers. Includes your emergency management agencies, any hospitals in your area, public health or the health department, urgent care side, alternate care side, community health clinics, primary care physicians, long-term care, behavioral health, dialysis labs, as well as in each district or throughout the state, there's what we call a national disaster medical system. A lot of times these are the run by the Veterans Affairs hospitals that push out then to incorporate or engage local hospitals within a national disaster level.
So where do the ambulatory surgery centers fit in? When we have a mass casualty incident within a community, one of the things that everyone needs to work towards is establishing bed availability. Within our healthcare coalition, our goal is to be able to provide an additional 20% bed availability of our hospital beds within 4 hours of a disaster. So basically that means that most hospitals currently operate at or near capacity, especially those hospitals that are designated as trauma centers. And in order for them to be able to accomplish increasing their bed availability, one of the things that they need to do is decompress or send patients that can be taken care of in a different type of a healthcare patient beds for incoming patients. Some of the things that the ambulatory surgery centers can do to assist with this is doing what we call overflow surgery. These could be surgeries or procedures that you normally do on a day-to-day basis where you let your hospital know what your capabilities and capacities are so that they can either divert some of their current caseloads, particularly if they were doing some outpatient surgical procedures, to you, or if they have some new patients that come in that don't need immediate surgery interventions but will need interventions in a very short period of time,
coordinate with you to transfer the patient to your surgery center for them to be managed in a outpatient surgery role or facility. Another type of response that your surgery center might be able to do is what we call triage. And this is basically when patients or victims of an incident present at an established area for an initial look to see what type of injuries they have, what categories, whether they need immediate hospital emergency department care for a life-threatening type of an injury. We typically call those red patients, whether they need medical interventions that's not life-threatening, but it can be delayed for a few hours, and we typically refer to those as yellow or delayed patients, or patients that are presenting with minor injuries, and those patients are typically referred to as green level patients, or those requiring minor interventions. And that would be the kind of patients that if you were to become a triage area, that the hospitals might try to direct those green patients in your direction for you to do further triage, and then possibly even some first aid type of intervention. Might be abrasion, some small lacerations, eye wash needs, possibly even some simple fractures for splinting. So again, things that don't require a lot of intervention, that can be managed, wound care, and minor procedures for the surgery centers to be able to handle. Another way that you might be used, if a particular hospital in your area would need to be evacuated, they're going to need, depending on the reason for evacuation, possibly need what we call staging areas for patients to be managed until the appropriate transportation can be provided to move those patients away from the affected hospital to a safe hospital. So you might be managing patients until their transportation arrives. Another type of staging area might be for patients that the hospital has determined that they can be discharged to home with home care, but again, they're waiting for transportation from the family members in order to release those patients back into their home care setting. And those patients need somewhere that they can be monitored and provide maybe power for an IV, temporary IV or something, until they can be picked up by a family member. So that might be an additional type of staging area that the surgery center might be able to provide. Again, we're talking about mass casualty type of incidents, not simple just surge to a hospital from like a bus crash or something. Other ways that these surgery centers might be utilized, and this is going to be more in cooperation with the public health departments versus an individual hospital for these type of events. You might be able to be used as what we call a family center. Anytime there's a mass casualty incident, there's going to be a lot of family members congregating either at the incident site or at the local hospital until they're reunited with their injured family members. And just depending on where you are in the community or close to that type of an incident, the health departments or the Red Cross would need to establish what we call a family center where these families could congregate. That happened just yesterday, unfortunately, in the shooting in Orlando. There needed to be a couple of different family centers established for those families of those over 100 victims that were affected by that incident. And anytime there's a victim, that's typically several different families and members and friends that come looking to be reconnected. So that's multiplied exponentially by the number of victims. Another way that an ambulatory surgery center might be utilized, again, because you have generators in case there is a power outage, you have different kind of areas set up, is what we call a charging station. This happened in Joplin, Missouri. It happened in the Gulf Shore states for the hurricanes. It happened in the Northeast states during the hurricanes. It could happen during some blizzard type of situations where individuals that are being managed at home but are dependent on electricity to run their respiratory support equipment or to provide necessary IVs just need to get plugged in, and an ambulatory surgery center might be converted to what we call a charging station. That's something that we get on that wouldn't necessarily affect your ability to continue your day-to-day surgical procedures, or it could be activity that can be done after all your surgical procedures are completed, just extending your hours into the evening and or weekends. Another way that surgery centers may be utilized is what we call the responder rest and rehab areas. The first responders in the actual community responding to an incident, and or if you're near a hospital setting, the healthcare providers and the staff within the hospital need rest. They need to be able to reconnect sometimes with their family members for short periods of time. And we've heard in some mass casualty type of situations where they've used nearby surgery centers to provide rest areas, either just for breaks and or even periods of sleep to first responders and healthcare workers in the hospital or clinic settings. And another way, again, working with the health department is what we call a point of distribution center, or you might hear it called a pod. This is where there needs to be a process set up for mass prophylaxis within a community, typically due to a bioterrorist type of a situation or an infectious disease situation where we need to very quickly be able to provide vaccinations to multiple people. And a surgery center might be a point where the health department could work with you and your staff to set up a point of distribution or pod for the general public to move through rapidly to obtain those critical vaccinations. Other ways, those are assuming that your surgery center is functional and operational, that you can continue to provide care and either to your patients or to victims within the community or the general public in the way that we just discussed. If, however, your building is compromised from either a physical damage or compromised due to a wide-scale utility long-term outage, or is in a restricted area due to either a hazardous situation or a not safe community environment, and you need to close your surgery center, kind of think about how your staff and supplies, where they're needed most. Are they, can you send your staff and your supplies, equipment to the hospital? Has your community set up alternate care sites or shelters where your staff and some of your supplies might be well utilized? Is there a field hospital or field triage area set up? Again, wherever you can be distributed, again, in a mass casualty type of situation to provide the most good for the most people. And one of the things that we would encourage you to do is for your staff to pre-register with the State Emergency Registry Volunteers in Indiana, also known as SERVE-IN, and this is the website to accomplish that registration. And it's a lot easier in a mass casualty type of situation if hospitals or health departments or the Red Cross or someone is needing to activate additional staff. And this doesn't necessarily just mean clinical staff. Your non-clinical staff can also register on SERVE-IN in order to support your community in a major type of disaster. It does go through some pre-credentialing. There's some training opportunities so that if activated, those individuals have some background information and knowledge in how to manage a mass casualty type of an incident. So those are just some of the different ways that the ambulatory surgery center might be utilized in a mass casualty type of situation within the healthcare coalition. Next, I want to talk about, so what if you either help with this, what do you need in order to do that, or if the surgery center is the incident, how that can affect you. So if you are going to provide some of those things we just talked about as far as triage or staging or point of distribution, these are some of the things that you're going to be able to, or going to need to develop plans for within your coalition and work with your healthcare partners to make sure that if you're utilized, that the coalition is supporting you to be able to accomplish that. So how can your space be utilized traditionally, or what non-traditional ways can your space be utilized? Your staff, what are you licensed to do? What kinds of procedures are you licensed to do? And in a mass casualty declared type of an incident, there is a process to get a waiver from the Indiana State Department of Health in order to be able to do different types of procedures than what you normally do if you have the staff, equipment, and resources to do that. But also look at, what are some of your other staff skills that maybe you don't need on a day-to-day basis, but they have a background that they can be utilized in other ways. It's important for you to know or have a list, as well as the partners that you're working with, to know what equipment and resources you have available. Do you have anesthesia ventilators? You probably have an AED. Several of the surgery centers have x-rays or C-arms. You might have 12-lead EKGs. Pretty much most of the different types of surgery centers have IV pumps. What kind do you have? What kinds of connecting resources do you have with those IV pumps? That might help in a mass casualty type of a situation. When you're doing your supply inventories, It's important for you to also know when your next shipments are due, where you are in that cycle, how you can get more resources from your normal vendors, and what of those resources can you temporarily loan to a hospital or an alternate care site until your supplies can be replenished. Also, if you're going to be used in some of these ways we talked about here, are you capable of providing food and water to those individuals that would come to you, or are those resources that you would need the community to help provide? The other thing to kind of look at when you're providing support to your community through the Healthcare Coalition is making sure you have systems or processes in place for incident command, that you have someone that can manage the incident from your standpoint, that you have the capability to monitor your building's safety features, as well as utility resources, that you have means for communication both internally and externally with your community partners. You have a system set up to track victims that present to you, either on their own or coordinated with your Healthcare Coalition. Again, that we can provide nourishment and water to those individuals in our care. And you kind of need to look at environmental services. If you have more people coming, that means more waste is produced, and how is that waste going to be handled until it can be disposed of properly. And looking at, again, safety and security, life safety issues. We don't want to extend the capacity within an ambulatory surgery center to the point that it becomes an unsafe environment. And with more people comes a need for increased security. Bad people take advantage in these situations, and we need to make sure that we keep everyone safe from harm. On the flip side, when we're looking at ambulatory surgery needs, we need to kind of think about, what if the incident is at your facility? What if you have some damage from a tornado or an earthquake? What if there's a workplace violence situation within your center? What if you have a utility failure to the point that you need to look at shutting down or sheltering in place in a hazardous material situation? So if you're involved in as the incident site, what do you need in order to provide injury assistance until EMS can respond to you and move injured victims to an appropriate treatment center? What type of security processes can be set up to manage patient flow or traffic flow to make sure that you are able to secure your premises and in the property that you own from, again, those people that might take advantage in a situation like this. If you need to move individuals away from your surgery center, what kind of transportation can be provided? Obviously, if there's injuries, you're going to work with the EMS or different ambulance systems. But sometimes it's a matter of trying to move individuals very quickly, either in your personal vehicles or through mass transport types of things. And those typically are arranged, again, through your emergency management agencies. You need to think about how you're going to manage your medical records. Some of the surgery centers are moving towards electronic health records with a good backup system so that those records can be accessed if your center is closed. However, most of the ambulatory surgery centers currently are on paper documentation. So how are those medical records going to be secured? Or if your facility is compromised and has to be closed with a total relocation, how are you going to safely move and store those medical records? Another thing to think about is your medication. If your power goes out for an extended period of time, once your generator fuel runs out, how are you going to manage refrigerated medications and narcotics? Do you have a agreement with your local hospital that they could temporarily store those in their pharmacy? From an equipment standpoint, your surgery centers have multi-million dollars tied up in equipment that you use to do the procedures that you do. So how are you going to protect those from the elements and from theft if that is an additional threat? And then also look at your continuity of operation. If you're going to be closed for an extended period of time, do you have an agreement with other ambulatory surgery centers to perhaps use their facility during their off hours so that you can continue some of your surgical scheduled procedures and maintain business operations? So how are you going to do this? What do you need to do to be a good partner within your healthcare organization? Looking at a district healthcare coalition, working with your local emergency management agency, and also your general hospitals that you typically work with on a day-to-day basis. And I provided you with a couple of documents that I want to switch to at this point. One of those is the Healthcare Coalition information. Within the state of Indiana, we are divided into 10 district healthcare coalitions. And you can see that those are outlined here and divided geographically within the state of Indiana. So depending on what county you live in, it's what healthcare coalition you are a part of. So you can kind of look at this map and determine, so where do I belong? What healthcare coalition do I need to become a good partner with? And you can get a list of the different hospitals that are in those counties if you don't have that by going to this site on the Indiana Department or Indiana State Department of Health. Has a list of all the hospitals that you can look at by county or by city. The next page is just the different hospitals that are listed in those different coalitions, the name of the hospital, what county they're in, and what city they're in, just so that you can see where all the hospitals fit within the healthcare coalition. And then I provided you with those 10 different healthcare coalitions who the primary contact person is. So you can see who is the chair of the district healthcare coalition. Some of them have business managers. I believe that one has a business manager. I just don't know that person's name. It's blank in 7 because they're a small district and they don't have a business manager. So you can see who the primary contact person is, who their business manager is, as well as who their district healthcare coordinator and their district public health coordinator. Who from the Indiana State Department of Health is assigned to that district as far as the healthcare preparedness program and the public health emergency preparedness program. If there's a blank here, it's because I personally don't have that information. As we move forward and update this, I can make sure I send that to Ann, and she can get that out to you or keep that current on your website.
Within the Indiana State Department of Health, the Public Health Preparedness and Emergency Response Division, again, split into the Healthcare Preparedness Program, which is where the ambulatory surgeries fit in, and the Public Health Emergency Preparedness, which is where the health departments fit in. And these are just to contact folks if you need to get in touch with them at the state level, as far as who are the directors of the Healthcare Preparedness Program or the PHEF program or Public Health Emergency Preparedness Program, Jerry Welsh or Megan Little. And you can see they've recently had name changes, so their emails don't match their current names. And then the state is divided from the district standpoint. They have area coordinators, Kara in the north and Chris in the south as far as the Health Care Preparedness Program, and Pat and Craig from the health department side. If you need to get in touch with your emergency management agency or figure out who is managing your local emergency management agency, you can go to this website through the Indiana Department of Homeland Security, and it has a list of all the emergency management agencies by county and current contact information for your local emergency management agency. Okay, another document that I wanted to show you is kind of, how you can get connected if you're not already connected with your district healthcare coalition. Each of the healthcare coalitions within the state have meetings. Some of them meet monthly, some of them meet every other month, some of them meet quarterly. So again, go back and contact whoever is either the chair or the business manager, depending on what district you're geographically located in, and find out when those meetings are and attend one or two of those meetings to see if it's something that you need to attend on a regular basis, or if I think within IFASC there's a emergency preparedness team lead that does try to attend those meetings that you can get connected to. The last page on that coalition, I just plotted out where the different ambulatory surgery centers there are within the state, so you can kind of see you're split up within the different districts. This is a list or the location where you can find a list of all the licensed ambulatory surgery centers. So when you're initially getting in touch with your healthcare coalition or your local emergency management agency or just your local hospital, you want to maybe provide them some information. This would be a good way to start that discussion is send them a letter. And so I've just provided you with a template on very simply how you can contact them, as well as some general information about your center, emergency or administrator contact and alternate contact information, what kinds of procedures you do, your hours of operation, the number of recovery and OR procedure rooms you have, the type of staff that you typically have within your facility. Once you are meeting individually with those, either the hospital, the district coalition, or your emergency management agency, some things you want to be prepared to discuss are, what can you do? What do you need to be able to do that? Do you need to have memorandums of understanding with a local hospital or with a particular vendor to get the resources that you need to be able to accomplish those activities, and again, who works there and what types of equipment or supplies that you have. You want to be able to provide them with an organizational chart, maps where you're located within the community, where you are within the building, what floor you're on, what entrance
you can be accessed through your specific floor plans as well as your evacuation map. And also, within the Healthcare Coalition, we've talked about briefly here and in other meetings, conducting hazard vulnerability analysis. These are the individuals you want to work with to make sure that your hazard vulnerability analysis kind of goes along with what's happening in the community.
Okay, I just wanted to share real quickly a couple different case studies on how surgery centers were affected in a mass casualty type of situation. The Health South St. Augustine Surgery Center in Florida post a hurricane. Some of the things that they did were they took collections of clothing, canned goods, etc. They were able to park a semi-trailer on their property and just help to distribute this to community members. They were positioned across from a police department, which helped be able to manage that distribution point. Over the course of, and I don't know exactly the course of how long this took, but this surgery center actually treated 300 people. Most of them had cuts or infected feet. Some of the victims were carried in or wheeled in shopping carts. So they were able to treat 300 people in a kind of a first aid station. They also arranged for tetanus to be overnighted to their center. So remember I talked earlier that you might work with the health department to become a point of distribution. And they administered over 200 tetanus vaccinations. They also administered IV fluids for victims that were presenting with dehydration and managed them until they could be safely discharged. Some of the serious types of cases that they were presented with that needed transportation to a hospital type of setting were dialysis victims, individuals in respiratory stress, and even one individual that was having a grand mal seizure when they were presented to the surgery center. Another surgery center that's pretty well publicized as far as how they help to manage during a major catastrophe was the State Line Surgery Center in Galena, Kansas, which is right next door to Joplin, Missouri. When the tornado initially went through, they called to confirm that their generator had kicked in and they could be operational. The administrator texted their staff and the physicians to go to the center, and they opened that center within 45 minutes of the tornado passing through. Through the police department, they did notify EMS or the ambulance services that they were established, and they were able to staff that surgery center from Sunday afternoon, which is when the tornado went through, continuously until Monday night. And during that time period, they treated 68 patients. Most of them were abrasions and simple fractures. And in order to support the community, they did apply for and received from the Kansas licensure, state licensure, to actually convert some of the rooms to inpatient status. So when the hospital beds were completely overwhelmed, they were able to operate on a 24-hour basis to have some patients there as inpatients. So kind of in summary, lessons learned, you want to make sure that you're prepared. You should make sure your staff are prepared to take care of themselves and their family, and that your center is prepared to care for your patients and your staff. You want to be proactive. You want to have a good emergency operations plan. All contingencies can't be predicted, and sometimes you may need to be flexible and improvise. You need critical thinkers, and sometimes you have to think outside of the box and see how you can fit into your community. So coalition, there are kind of four
words that we typically want to focus on when we talk about a coalition: communication, sharing that information, and situation awareness, making sure that you have interoperable or redundant communication systems, that you use common terminology, and you're honest and clear in your communication. Another word that we focus on when we talk about coalitions is cooperation, or your willingness to work with one another. Coordination, this is working together harmoniously, doing that joint planning. And collaboration is the action of actually working together, and either with your peers or sometimes even your enemies or those that on a day-to-day basis you would compete with. You want to make sure through your coalition that you participate in all the joint training activities that are offered. I know IFASC has done a wonderful job of making training available to the surgery centers specifically, but your coalition also has a lot of different training opportunities that you can participate in. Each district does have to do through the healthcare preparedness program exercises for the whole community, and so make sure that you know when those exercises are and participate in those exercises. It may just be, particularly if this is the first opportunity you have to join your coalition, that you're just observing at your hospital as far as how they're managing an incident, and maybe have an opportunity within that to discuss how you could collaborate or cooperate during a mass casualty type of an incident and support each other. Anne asked me to share with you that she is conducting an emergency preparedness survey. So all the members of IFASC must complete this survey in order for them to capture what capabilities the surgery center has, what resources might be available, and what you need to continue to operate your businesses. The deadline to complete this survey is June 30th. The link here to the survey, or you can contact Ann Haddix and get the link from her if you don't currently have it. But again, that survey does need to be completed by June 30th, which is coming up very quickly. And last, just want to share with you the remaining trainings that we have this month for the surgery centers on June 23rd, which is in a week and a half on a Thursday. We will be talking about infectious disease, some of the different emerging diseases that the CDC is monitoring and we need to watch, how these surgery centers would manage infectious disease, and talk about a pandemic type of a situation, how that might affect a surgery center. And then on June 27th is the rescheduled active shooter training for the North region at Lutheran Hospital from 2 to 4. So if you've not registered for either the webinar or the training for active shooter training, please do that. Again, just my contact information or Jeff's contact information if you have any questions or need any certificates of training, please contact either one of us and we'll make sure that you get those. So I'm going to just go back as we end back to the slide so that you have an opportunity to capture that survey link from Anne if you need that. So I'm going to unmute everyone. If there's any questions, please feel free to speak up or to post a note here in the chat feature. I'll stay online for 2 or 3 more minutes in order to address any questions.
Joyce, I have a question.
Yes, ma'am.
Are you there? This is Denise Cutter at Avon. At the very beginning, I lost a really important point that I thought you made. Was you stated that I think hospitals would be required to increase their capacity by 20% within a 4-hour period. Can you go over that?
Yeah, it's not each individual hospital, it's the district group as a whole. So if there's some trauma hospitals or larger hospitals and there's some critical access hospitals, it's a collective effort within all the hospitals in their setting or in that district to increase their bed capability by 20%.
Got it. Okay. Thank you.
Uh-huh. Okay, I think that's all the questions. So again, I'd like to thank everyone for joining the webinar today. And if you have any additional questions, feel free to email me at your convenience.